Welcome to the Fed to Fed podcast, where we dive into the dynamic world of government technology. In this podcast series, we'll be joined by current and former federal leaders and industry trailblazers who are at the forefront of innovation. Here, we speak openly and honestly about the challenges and opportunities facing the federal government and the Department of Defense and its partners in the modern age, driving innovation and the incredible capabilities of technology along the way. Whether you're a federal leader, a tech industry professional, or simply fascinated by IT modernization, just like us, this podcast is for you. And we're so happy to have you tuning in. Scott, thank you so much for joining us today.
Good seeing you, Susan. I've always liked working with you over the years, and it's been many years.
It has been. And the best part is we so appreciate you always bringing your subject matter expertise to the table, and we're really looking forward to this discussion today.
Thank you. Again, if anybody has ever seen me speak when I was in uniform, I was pretty passionate about what I did in the mission sets.
Right on.
Thank you.
And you still are. And that's
I
why
am.
those are the things that we're going to talk about today. So, Scott, what are you seeing over at DHA? There's new leadership taking the helm or has taken the helm. Tell us a little bit more of what you're seeing and what you're thinking about.
So as leaving the DHA, and I equate the DHA to a very new organization. If you're coming from a legacy organization that has a firmly defined mission essential task list, Army calls it a medal. Everybody trains to the medal. With new organizations, sometimes the medal, the mission essential task list, migrates to the personality or the priorities of the new leader. Case in point, General Crossan was very focused on institutional medicine, and Admiral Vai, based on his background, is very focused on operational medicine. Both are 100% right, but the people in industry specifically have to adjust and pivot to those changing priorities. And sometimes the agency has long-term contracts in place. Funding has already been, I would say, debated and allocated. And when priorities change, resources change. And then the agency has to respond to the changing priorities, and then industry has to change. And oftentimes it takes time to adjust the priorities, the processes, and the mission set of both industry and the agency to support those new priorities by the new boss. And it's not bad. It's just the nature of business, and industry is doing the best it can to accommodate the new direction of the new director.
Scott, can you tell us a little bit more about that new direction and things that industry should be thinking about to align with those priorities and initiatives?
Sure. The new director is all about operational readiness. Perfect at the time with what we're doing in the Middle East, warfighter support, getting the service members ready to fight, and the medical support entities ready to treat in very unique environment. It's different than training in the institutional side. So the director with the services have to be able to convey the mission set to get the forces ready and the tools necessary to make sure they're ready. You can use metrics for readiness, and then metrics for the capability of the provider, and not just the provider, the doctors, the nurses, all the supporting staff that deploy, to include logistics, and to be ready to support the fight. I came up through the world of you train as you fight. It might be a little disconnected now because some of the things that I have seen is the people that deploy take the tools and techniques that they learned in garrison into the fight and adjust. They don't learn a new way of doing business in a new theater of operation. They modify their existing tactics, tools, and procedures to the environment that they're operating in. That's what I see as changing.
Gotcha. What advice do you have for industry in terms of opportunities to come? Some gaps that you're seeing there, some ways in which industry can help support the mission?
I think first and foremost, if you're trying to sell a product, I would say that that's risky because oftentimes, because of the DHA is an agency now and looking at enterprise solutions, they're not going to want to quote unquote rip and replace. Okay. With the operational side of the house, it has to work in the environment where we fight. And selling commercial product might work, but does it necessarily work in a low com, no com environment? Does it work in a low bandwidth? Does it work in excessive heat, dust, and humidity? Does that piece of equipment work on the ground, in the air, in transport? And do we have the people trained to maintain and sustain those pieces of equipment that are now being deployed? When I went to this is again, I'm older, but Desert Storm was a very learning experience for me, where I deployed from with the 101st, but many of my clinicians came from facilities that were expecting facility-like equipment. So having them go through my sets that I maintained and taking out what they didn't know how to use or didn't want to use and replace it with new technology that they were comfortable with helped when with the development of forward surgical teams, for example, back in the early 90s. And I think we evolved to constantly do that. And so industry understand the Department of War and their mission set and where they want to go, and stop skating to where the puck is and start skating to where you believe the puck is going to be, and be flexible to that, to a hockey term, a deflection. And if it's so rigid, it's very hard to penetrate that. So if it's a application, it's a product, how it can enable and enhance the warfighter survivability in combat. That's kind of my advice. Trying to sell, I mean, I just seen the news, they're developing portable data centers, which I would have never thought of, but industry is forward thinking that the data that people are customized to use in the garrison are going to need that same sort of data fidelity and breadth and depth of availability in theater. So industry is adapting to making sure that data is somehow available and reliable in those austere environments.
Thank you for sharing that. Scott, you and I attended an event on the end of March all around supply chain. We had experts there from all different agencies: FDA, VA, DHA, DLA, DOD, or Department of War now. Can you tell me a little bit more about the focus that people should be thinking about now regarding supply chain and what is happening, and those gaps, those things that are missing in the thinking and planning?
Yeah, first of all, it was a great event. And for a medical law guy like me from Army, it was like old home week for seeing some of my students and many of my peers, and they're all experts in their field and great insight. I coined a phrase: "We live for lessons learned, and very seldom learn our lesson." And and I think it's because the medical logistician from the past, we really didn't care about the process. Processes were important, but outcomes were more important. And what I mean by that is, in our community, our major end item does very poorly waiting for parts or waiting for service, and that's the human. Where if you're a line logistician, your tank, your vehicle, your airframe can sit waiting for parts or sit waiting for services. So our medical logistician community, across all services, figure out a way to solve the complex problem, even though the process didn't support the outcome. I think today is we're so tied to technology and automated processes that we might lose that flexibility to operate more focused on the outcome rather than the tools of the process. And I'm not casting dispersions on technology,
Hmm.
but that patient doesn't care if the electron is down or the request didn't go through electronically. We had hand carried notes from our aid station back to the supply point, and everybody's talking about transmitting with different technology. But we have to work on the outcome and never lose fact that piece of equipment, that pharmaceutical or the consumable is in response to a patient need or a casualty need. And I think that needs to be always first and foremost in our decision making. And then we capture the lessons learned. We try to institute new policies and processes. But like most operators will tell you, good plan only is through first contact, and then everything changes. And you just having those young logisticians and senior logisticians able to think on their feet to work around, I'll call them clanks in the process to get to the right outcome.
Thank you, Scott. So there's been many discussions about the pandemic and the resiliency of our supply chain. Is there an aspect of medical logistics, pandemic, or contingency planning that should be part of the discussion?
Yeah, my best. I mean, I might upset someone at my old former 76 Juliets, which were medical supply technicians. My best legit med log person was a pharmacist, and he taught me to think in clinical terms rather than national stock numbers in a system approach. And I think that paid well dividends for me in Desert Storm and when I went as Iraq supporting the coalition provisional authority. And when I say that, real world example, Desert Storm, my division surgeon wanted to triple the number of D-cylinder oxygen tanks for the ground ambulances and air ambulances. And I had pallets of them arrive with regulators because I believe that's what we needed. Come to find out is those 300 or 400 oxygen tanks were non-mission capable because as a logistician, no one really explained to me that there's a yoke adapter that connects the regulator to the tank. And if you don't order the yoke adapters, those pieces of equipment are inoperable. So now I think of a system to system approach, not just an IV, but it's an IV bag. It's the needle, the catheter, the starter kit, and all the other consumables required to initiate the IV. So I focus on treatment protocols rather than individual widgets. And people are talking category management. And I think category management is a good idea to the extent, but it has to be translated into treatment categories. So when your clinician is engaged, he's not knowing the stock number. He has a gunshot wound in a lower leg. He has a chest wound. He's got a burn. And it's like the tools need to be necessary to translate the clinical language into items that are stored in stock to be packaged and delivered. And for the pandemic, uh, I was back for not for COVID pandemic. I was the DoD medical director for medical logistics policy director for OSD. I got brought into the H1N1 pandemic planning. There, it was all about Tamiflu, antivirals, PPE, and developing stockages for that. But then I got into treatment because I'm not a clinician. Most of the clinicians indicated that the greatest risk of death is from pneumonia as a result of contracting H1N1. So sitting down with the clinicians, it's what treatment protocols did we need to treat from the different antibiotics that were available, and not just the medication, the antibiotics, but it's also the needles and the syringes and everything that went into making sure that you could distribute or deliver the the treatment timely. And it isn't just one treatment. So working with my clinicians, how many days of antibiotics would this patient need? So I worked with them to calculate my contingency stock for antibiotics based on how many days of treatment for a particular patient based on the guidance that the clinicians drove. And then I backwards planned into DLA. We couldn't stock it all, so we had vendor managed inventory. And then the other thing that we worked very closely with the services at that time with health affairs is pre-positioning those antibiotics in a number that could be consumed but not wasted because the facilities where it was located consumed those same antibiotics. So not every hospital or clinic in the Department of Defense at that time had the same access to those antibiotics. They were pre-positioned where the most use would be, and we developed a rotate. We didn't do 100% stockage of what we needed for the pandemic. We just increased their current stockage by about 30%, so they could rotate the stock with minimal waste due to the drugs expiring. And in the end, which was important because I did this I created a POM line, program of objective, to fund it because I had to defend those dollars with the budget people. And this allowed leadership to defend cost versus readiness. I could have asked for the world. I need 100% of everything, which was a very expensive endeavor. But defending that I can't ask for everything, but at what level are the health leaders willing to go to budget people and said, we can accept this level of risk for this much money. And they did that and they funded it, which was very successful. I was hopefully they use some of the same types of lessons learned and tools that we had back in early 2000 for what happened with the COVID in 2020. Because logistics plan, but you also have to plan to defend your plan with the guys that fight for the money. And that's where I think the partnership between resource management and logistics needs to be strengthened. I'm not a clinician. I'm not making those clinical decisions. I'm carrying the message from the clinicians to the resource managers to make the clinicians with the logistics and the research managers fight as a single team and defend it.
Thank you for sharing that. That's amazing perspective. So, Scott, you talked a little bit about technology. AI is becoming an important part of medical logistics and clinical practice. Can you give an example on how AI could connect the supply chain with clinical practices within the Department of War?
I sat back when I was still in uniform. I said, there should be a way to where I use the adage, a good logistician is someone who is an unknown logistician, meaning they work very hard to anticipate what will be needed. Because what you don't want to hear in an OR is the clinician yelling for the logistician, where's my X? Where's my Y? So I sit there and think with the technology that we're using today, is there capability for we can run scenarios of injuries. When I was doing simulations, the only thing that we had to use for planning purposes was blood by type and short tons of supply. Now with technology, you can actually get into individual treatment. So you have the ICD-10s. You can run scenarios with different ICD-10s from point of injury and making the assumption that technology is working, that the electronic health record is deployed and the treatment is being collected, the patient record is being moved. So if he's being moved from a level 1 to a level 2 to out of theater evacuation, by the time it gets to a level 3, the logistics people should have a well understanding of what's needed to treat that patient and not wait to re-diagnose, then reorder, and then ship to delay treatment. I think the connection between the patient record and the logistics files is critical. So when that patient lands, that treatment package, almost like a surgical pack, is waiting for the patient when they arrive. If the technology allows that to occur, but you have enough information from converting it to treatment to an ICD-10 to map it to what type of antibiotic, what type of IV, what type of suture, different burn pads, whatever this logistical need is, should be there waiting for the patient when it lands rather than being requested for. It should be pushed to with the technology if it's available. And we're working hard in connecting that clinical practice with the logistic availability. And then a second nature is if you don't have that particular product is there a suitable substitute that you don't have to search, but AI could scan your inventory? Yes, that a 4.0 suture won't work, but a 3.0 suture would work. Type of methodology utilizing AI.
I love that, Scott. So let's go back to your original conversation or a discussion around operational medicine. Is that being done now? How does the Defense Health Agency and or industry address that and
Well,
make that happen?
So, and I think December of 2024, JOMIS, PM JOMIS issued an RFI for operational logistics. To date, which I think is, this is April 21st, nothing really happened. So I don't really know what's going on. And my fear is that the supply systems in technology that we used when I was younger was the same in theater, was the same that we used in garrison, might be different. And that's a concern for me if the theater logistics people are not talking to the institutional logistics people to make sure that you're not learning a different I'll show my age, trying to learn how to use Harvard graphics and while you're deployed with PowerPoint. The closer you get it to the same, the more comfortable people are in using it, especially when they're losing sleep, incoming, constantly having to move because of technology and the electronic footprint that could potentially expose the casualty locations or the treatment locations. And so what's happening in operational medicine, I almost seems like it's occurring quietly and not openly. And I think having constant engagement with industry of what they're thinking would pay off huge dividends downstream. Because there's a lot of companies, a lot of industry partners that have unbelievable solutions, but they don't know what to bring it to because they're not following because all they have is the RFI from 2024. And they know that the institutional side is really focused on logical. Is it the same? Is it not the same? The functions needing to be different. And I think that applies to medical maintenance. One of my greatest bosses, she was the Deputy Assistant Secretary for Force Health Deputy Assistant Secretary for Health, Force Health Protection and Readiness, Ellen Embry, was bring as far forward as you can the clinical practice to where it can be to generate the best outcomes, and then pivot. And I worked hard with her on standardization, but we changed the term. We tried to change the term because clinicians don't like the words standardization. So some of my senior mentors in the med law community, what we wanted to do in the supply chain is not standardize, but reduce unwanted variation in it. And what I mean by that is sometimes things need to be different, but it's those known changes that are captured and identified. What spins a supply chain out of control is when you have hundreds of unknown variation that you can't respond to. So standardization in my world is just reducing the unwanted variation. And when you capture that variation, analyze it, research it, and accept it as part of the new process in operational medicine.
So, Scott, in closing, what are your suggestions to move this forward?
First suggestion is more engagement in industry. If you want to be a strategic partner, treat industry as a strategic partner and not just as a cost element or a contractor. A large percentage of the workforce in Department of War is supported by contractors. Health is huge. Housekeepers, food service, all the administration, a lot of logistics, many of the clinical services, nurses, allied health, clinicians support the warfighter in their own way. Treat him as a partner, and then be transparent. Okay, we don't have all the answers, but by working together we could solve a lot of the problems. I did want to touch on one other aspect.
Mhm.
Related to based on the call that the conference that we attended. In my experience, we do a lot of discussion about the Defense Production Act, which I understand that POTUS has invoked for today for some of these efforts in this operation. Manufacturing is one thing. I think that we need to think a little bit harder on, I don't know what the term is. I'll just call it a Defense Distribution Act. Because limited resources are available, it isn't necessarily the first person that places the order should be getting the order. And in Department of War, we are part of the global supply chain. Okay, we are subject to the same risk and fragility of the supply chain, and we have to be cognizant of the fact we just don't come in and take. So we have to work, and I mean by the Defense Distribution Act is you might have it on order, you might be first in line to receive it, but based on the analytics, are you the number one priority for that particular product or goods or service? We do it in combat. They call it command controlled items. When I was in the Army, certain things were command directed to be released or not to be released based on the phase of the operation. And I think if we look at that into distribution, we won't have the hoarding of the first in scooping everything up, and the people that need it the most are scrambling to get it. So I think that's an important logistical and operational discussion needs to occur not just within Department of War, but within FEMA, NDMS, because medical supplies are limited and very subject to OCONUS influence because some of those things we just don't manufacture, and the raw material doesn't exist in the United States.
Thank you, Scott. Scott, anytime that I have the opportunity to meet with you one-on-one or when you're with other groups of people, you're always so passionate and focused on the mission, and you're always so kind to share solutions, challenges, but solutions and things that you know that have worked in the past. And I can't thank you enough always for your time and also for the way in which you care so much about the work that you've done and the work that you've led and the things that you can continue to drive. So, Scott, thank you so much for your time today. And as always, for everything that you've done for this community.
Susan, people really respect you and what you do for the community. And I think we've known each other for 15 years, and today is like your first day we met, day one, about looking after the veteran and looking after the military member and their family member. And everybody owes a lot to you as well.
Thank you, Scott. Well, thank you for your time. I can't wait for the next discussion.
I can't wait either. It's been fun.
This concludes today's episode of the Fed to Fed podcast. If you enjoyed this episode, please don't forget to subscribe, rate, and leave a review. Your feedback helps us continue bringing you thought-provoking conversations with the brightest minds in government technology. Stay tuned for our next episode, where we will continue to explore opportunities to harness the power of technology and explore what's next in developing a more innovative and efficient government. Until then, this is the Fed to Fed podcast by GovTech Connects. Thank you for joining us.